Good evening, dear students. Today we are going to discuss about a child with floppiness, that is floppy infant. What do you mean by floppy infant? Whenever a child is born, it should move his limbs, it should move his upper limbs, lower limbs, etc. If the child doesn't move his upper limb and lower limb, what will happen? And if it will look like as if the child is lying in a frog-leg position without moving any limbs. I repeat, without moving any limbs. This is called frog-leg position. This is called floppiness or weakness. So how to approach a case of floppiness or weakness whenever a child is presenting with? What will be the manifestation of this floppy infant? We all know that the child is floppy, limping, not moving the limbs properly, not moving the upper limb against gravity, not elevating the lower limbs against gravity. If at all, what will be the other manifestations? The manifestations are, what are all the manifestations? Let's see. The manifestations are basically one. The child will be ventilatory dependent immediately after birth. The child will be ventilatory dependent. You all know that you need to have your neuromuscular system. Your chest should expand properly. Your diaphragm, your intercostal muscles and external intercostal muscles and everything should expand properly, should contract and relax so that air will be sucked in and expelled out for respiration. Whenever these muscles are weak, the chest wall will not move, as a result of which the child will be floppy and ventilatory dependent. One. Second point is, as I told you, the child will be in frog-leg position with the extended upper limb and lower limb without elevating it against the gravity. So what is the second one? Frog-leg position. Second one is frog-leg position. Third one, in boys, mainly it can be a manifestation of an underlying undescended testis. It can manifest with undescended testis. So boys with undescended testis should be evaluated for some issues with respect to neuromuscular system. And finally, is there any antenatal clue? If the child is not moving the limbs properly, there will be reduced fetal movements during the antenatal period. So next one is reduced fetal movements during the antenatal period. Fetal movements during the antenatal period. The last but not least is the mother can present with polyhydramnios. If there is an issue with respect to, you all know, there are 21 muscles are acting at a single point of time during deglutition, swallowing. So if these muscles are not acting properly, the fetus cannot swallow the amniotic fluid, as a result of which the mother can have polyhydramnios. The mother can have polyhydramnios. So the manifestation of a flop, and also the child is more prone for because of aspiration. The child can prone for aspiration induced pneumonia. Aspiration induced pneumonia. The child can go for aspiration pneumonia. And finally, because of the mucus plug obstruction, the lung can go for collapse. Mucus plug obstruction, the lung can go for collapse. So the manifestations of floppy infancy in a newborn period immediately after birth are aspiration pneumonia, collapse of lung, ventilatory dependent cases, frog-leg position, undescended testis, and antenatal clues are polyhydramnios and reduced fetal movements. Okay, what do you mean by? So this is the manifestation of a floppy infant. Then let us come to motor unit. What do you mean by a motor unit? The motor unit is defined as It starts from anterior horn cell. It starts from anterior horn cell. It travels as a peripheral nerve from the anterior horn cell, and then peripheral nerve goes and join the neuromuscular junction and join the muscle, where you can have a neuromuscular junction, and finally it elicits action potential in the muscle. Finally it elicits an action potential in the muscle, right? So the motor unit, any problem with respect to the motor unit can lead to floppiness. So this floppiness can be due to lesions in the anterior horn cell, peripheral nerve, neuromuscular junction, muscle. These are all the places from where these lesions can lead to floppiness, right? How to know about the whether the child is having which site of pathology? How to know about that? Very simple. Let us forget about that upper motor neuron. Let us focus on lower motor neuron. Lower motor neuron means it starts from the anterior horn cell. Okay, so anterior horn cell. What happens in anterior horn cell? In anterior horn cell there will not be any seizures. Why there will not be any seizure? Seizure is the manifestation of the cortical involvement. So whenever seizures are present along with floppiness, most probably it is a case of cerebral involvement rather than anterior horn cell involvement. Weakness. Anterior horn cell is the place where many fibers will arise, form a motor unit and supply the peripheral nerve and supply the muscle. If anterior cells are affected, the weakness is profound weakness. The child cannot elevate the limb against gravity. Profound weakness. Floppy. The child will be floppy. Reflexes. What will happen to reflexes? Reflexes travel ascending nerve, anterior horn cell, then descending nerve, then comes to the muscle. If reflexes are also, what will happen in anterior horn cell involvement? Reflexes are absent. Reflexes are absent. What about plantar? Plantar, extensor plantar is a manifestation of upper motor neuron. Okay, this is a part of lower motor neuron. So plantar is not extensor. Plantar is not extensor. And finally, whether any sensory involvement will be there? No sensory involvement, because this is anterior horn cell. What is the most common disease? Most common prototype example? The example is called as spinal muscular atrophy. What we call it as SMA. SMA means spinal muscular atrophy. You would have heard about an anterior horn cell disease in an adult called as amyotrophic lateral sclerosis. So what will happen? The anterior horn cell will undergo degeneration in elderly age group, leading to that disease. You would have heard about Stephen Hopkins, a famous scientist who is interested in reading the universe, Milky Way, everything. He suffered from amyotrophic lateral sclerosis. In the same way, if there is degeneration of anterior horn cells in the newborn period itself, it is called spinal muscular atrophy. Second, what will happen when there is a problem in peripheral nerve? So see, will you get any seizures? No, you won't get any seizures. You won't get any seizures. Weakness will be not that profound. Weakness will be there, but not to the extent of the weakness that you get in anterior horn cell. Tone will be reduced, not floppy. Reflexes will be sluggish. Since it is a manifestation of a peripheral neuropathy, what will happen? Your knee reflex will be present, but ankle reflex will be sluggish. Okay, leave alone this plantar. Sensory involvement will be there. Sensory involvement will be there. Because of the sensory involvement, absence of pain, the child can go for trophic ulcer. So what is this disease called as? This is the disease that can affect peripheral nerve. It can be acquired or congenital. Acquired disease is called Guillain-Barré syndrome, whereas congenital disease is called Charcot-Marie-Tooth disease. Charcot-Marie-Tooth disease is a congenitally presence of demyelination. The demyelination starts from in utero, whereas your Guillain-Barré syndrome, the demyelination occurs as a result of post-viral or any post-vaccine issues. A neuromuscular junction. So what is the manifestation of a neuromuscular junction? The manifestation of a neuromuscular junction is fatigable weakness. So here also seizures will not be there. Weakness is fatigable weakness. What do you mean by fatigable weakness? Morning he will be blinking like anything, but evening slowly the doses starts. Morning he could speak in sentences, words. He can speak a big sentence, 3 sentence, 4 sentence at a stretch. But during the evening hours he can't speak loudly. He will speak with bits and bits. He cannot complete even a single sentence. He could do only 2 or 3 words. This is called fatigable weakness or diurnal variation. This fatigable weakness or diurnal variation is the manifestation of neuromuscular junction disorder. The most common disease is myasthenia gravis. The most common disease is myasthenia gravis, which occurs as a result of antibodies to acetylcholine receptors in the synapse. Tone will be normal usually. Reflexes will be normal usually. Plantar will be normal usually. Sensory will not be affected in myasthenia gravis. And finally, muscle. In muscle, you can have 2 things. One is muscular dystrophy. You would have heard about Duchenne muscular dystrophy, where there is degeneration of the dystrophy. Because of the absence of the dystrophy, there is degeneration of the sarcolemma leading to muscle death. That is called Duchenne muscular dystrophy. Or else congenitally there will be a structural problem in the muscle membrane protein. Those diseases are called as myopathy. Those diseases are called as myopathy. So in muscle diseases also seizures will not be there. And the weakness, you allow relentless progression. 3 years he could not walk. 4 years he could not even stand. 7 years he will be bedridden. By about 10 years, because of the involvement of diaphragm, he may die during sleep. What you would have seen in a movie called Thora. Nagarjuna has got paraparesis. Nighttime nocturnal hypoventilation comes and he gets up. And he finds it very difficult to get up from the bed. The same thing can happen to these children when there is progression of the muscle degeneration. So weakness will be profound and it will be progressive. Weakness will be profound and it will be progressive. Tone will be normal. Reflexes will be normal. Plantar will be normal. Sensations will not be affected. So the lower motor neuron lesions is characterized by involvement of anterior onsal nerves, neuromuscular junction and muscle. Okay, so these are all the typical floppy infant. Whereas what is the manifestation of an upper motor involvement? What is the manifestation of an upper motor involvement? The upper motor involvement is characterized by seizures. The upper motor neuron is characterized by seizures, and the tone will be high. They will have hypertonia, spasticity rather than flaccidity. Whereas these things are characterized by flaccidity or floppiness, whereas upper motor neuron is characterized by spasticity. Weakness will be present. Reflexes will be exaggerated. Plantar will be extensor plantar. Sensory may or may not be affected. So whenever any child comes with weakness, it can be either upper motor neuron or lower motor neuron. Upper motor neuron is characterized by characterized by seizure. Lower motor neuron, no seizures. Upper motor neuron weakness, lower motor neuron also weakness. Tone will be hypertonia spasticity. Tone will be hypotonic in lower motor neuron. Reflexes are exaggerated, brisk reflex in case of upper motor neuron, reduced or absent reflex in case of lower motor neuron. Plantar will be extensor in case of upper motor neuron, flexor in case of lower motor neuron. Sensory may or may not be affected in upper motor neuron, affected in diseases involving peripheral nerve. So lower motor neuron is characterized by profound weakness, floppiness. The most common cause is spinal muscular atrophy. It is characterized by tongue fasciculation. Do you like to see tongue fasciculation? Tongue fasciculation is look at this video. Look at this. Look at the fasciculation. Look at how the tongue muscles are moving here and there. This is called tongue fasciculation. Okay. So this is not taken from any Google videos. This is our own patient. Look at this. There is fasciculation of the tongue. Look at this. Fasciculations of the tongue. Tongue fasciculation is suggestive of what? Spinal muscular atrophy or anterior horn cell involvement. Again, let me repeat, tongue fasciculation. Look at this. Where else you will see these things? Tongue fasciculations are manifest. They are moving like anything inside the mouth. The child is not moving. There are fasciculations involving look at this. There are also pooling of secretion. The child could not swallow. This is called tongue fasciculation. Tongue fasciculation is suggestive of what? Spinal muscular atrophy. Look at this. This child is, look at this. This child is floppy. Don't think that the child is sleeping. The child is totally floppy. Look at the extensor. Look at the extensor. Look at the extensor aspect of the extensor position of the upper limb. So this is called a floppy infant. Any child who is oxygen dependent and floppy, you need to rule out spinal muscular atrophy. Unfortunately, we could not revive this patient. And look at this. Look at the eyes of the child. Look at the eyes of the child. There is ptosis. Look at this. The eyes of the child, ptosis. So this ptosis with the diurnal variation is the manifestation of what? Myasthenia gravis. Is called as what? Myasthenia gravis. Okay. And finally, the last one, what is this? This is called Scissoring gait. This is called as what? Scissoring gait. Scissoring gait is characteristic of a specific type of cerebral palsy called as what? Cerebral palsy. This is called spastic diplegia, where both upper limb will also spastic, lower limb will also spastic, but lower limb involvement will be more compared to upper limb involvement. I repeat, lower limb involvement will be more compared to upper limb involvement, and this lower limb involvement leads to the spasticity of the adductor magnus, as a result of which the child is having scissoring gait. So this is called scissoring of lower limb. Scissoring of lower limb is suggestive of what? Spastic diplegia, which occurs mainly in preterms who suffered from intraventricular hemorrhage or birth asphyxia. This scissoring is suggestive of preterm with spastic diplegia. Right? So with this, we are finishing our topic for today. So today you have learned, what are all the things you have learned? How to see a case of floppy infant, and what are all the lesions and what will be the manifestations of those lesions whenever any child presents with, and finally what is called Scissoring Gait. So thanks for your patient listening for this Thursday. We'll meet soon on next Wednesday and Thursday, same time between 9 to 9:15 p.m. Thank you. Bye-bye.